Let me ask Harry, epidemiologist, population scientist, and cardiovascular. What do you think? Is it possible to go and replicate something like PSA and prostate cancer with
so I guess first of all, it's of course not an or, so it's all plus plus plus. And so the primordial prevention, screening, and trying to do this is simply crucial. I mean, in this field, with the three things together, you can really do a good job, and you are already doing a good job. So yeah, if you can find a test that predicts mortality in the next 2 years or so, I think, except for people that don't want to know whether they are dying, for the many other ones, you have very good therapy. So it would be really crucial. Of course, in this respect, I would imagine that the calcium scoring is such a good test at the moment that you should come up with something very, very good to beat with like basically or whatever. But I think it's a good initiative.
Thank you.
But I'm a little bit skeptical. I want to come back what Jagat said. If we talk about the test, whatever the test would look like, and I mean, he mentioned the prospect and the different criteria that have been developed regarding vulnerable plaque. You identify more and more specific, but a small population, and still the vast majority in that trial, 0 events, with these specific criteria, didn't have an event, but the vast majority of MI still came from those who did not have those. So I'm a little bit skeptical. That
You're skeptical about finding one single test?
Yeah,
I'm with you 100%. I don't think we will be able to find a PSA. What I think we should be able to find is a combination of that vulnerable patient, plaque, blood, and myocardium. If you're able to draw something that combines these three, and whatever other information, obviously age and all the things here, machine learning, again, this is not something that you and I are going to come and sit down and put a binary score. This has to be done with, huge processing ability and the unique type of data set that we just talked about. Those people who have had an event in a few days to a few months.
But obviously you also have to adapt these approaches to the different scenarios that we have talked about. I mean, you go from primordial prevention to these very, very high-risk patients. I mean, these are totally different scenarios. So.
But we're not going to change the primordial. That's already there. I think Harry just said that. Then we need to have multi-pronged approach. That will stay. The society level, even Dr. Fusu's approach to home and family-based education has to be there. It all has to be there. What we are trying, past 15 years focusing is the identification of the vulnerable patient. People who are right close to the cliff and they're just blindfolded and they just fall and we don't have any way to identify it. And cholesterol and other risk factors are not cutting.
The problem is that we will have to go to a very big population to get a very small result. That is our problem in this whole issue. For example, I'll tell you, we presented one paper in ACC this year, and then we just completed a survey based on that, which we submitted for this coming ACC. This was the women who went for their mammography. I don't know if you chance upon that paper.
Yeah.
Now you do the mammography and you find the breast arterial calcification in them. And is Khurram was here, right? Khurram left? Okay. So Khurram did an editorial on it, fabulous editorial that he wrote. So the approximately 40%, 42% of women had breast arterial calcification. That was a biased sample. The reason being that we picked up only those who had mammography done as well as a CT scanning, I mean CT of lung done. So we did the ungated calcium scores in that. And we find out that 47% of those women, and these are all 40s and 50s, you know, where you would not do any kind of a test in these women, right? 47% of them have concomitant coronary artery calcium also, right? So Khurram did the analysis on it and beautifully written that we do approximately 40 million mammograms a year, right? Out of 40 million, even if we say that this was an absolutely biased population, 4 times biased population, at least we have 10% of them who have a likelihood of having calcium in their coronary artery, which otherwise we would have never thought in these women. Right?
You already answered
So
that
you have now 4 million women, right, every year who are likely to have the coronary calcium. Okay, and now what do we do with these women? So basically, we will tell these 4 million women that okay, you go ahead. I mean 10%. So out of them, 47% have. So 2 million women. What do? You change their lifestyle. What do we say?
I think you just made the argument. You just said we're trying to do multiple ways to identify them.
Right.
But
So I tell you. So today we did we submitted the late breaking abstract today for ACC. We find out that 85% of them said that they want to be informed and they would like to find a remedial measure. Now I don't know how far would it go, how many of them will accept it, what change would it bring, I have no idea. But they want to be informed.
I think that's a great movement. I mean, that's a great step. We should put that in national policy. Like FDA, CDC take this as a guideline.
National policy will take it, but
I mean, we were just talking about that to make a change, meaningful change, it has to be multifactorial. And so social impact and social education and guidelines and policies are one of them. But, you know, the SHAPE group said, collectively, that the first cut should be knowing if you have zero coronary calcium or you have a lot of calcium, because that will give us a good starting point. And then from there, we build on whatever machine learning tells us, guide us that adding these will bring you to that, you know, that threshold. You know, late George Diamond and Sanjay Cole, after our SHAPE guideline when we issued, they did the analysis. They actually said we need to screen about 48, 49 million people. But it's not every year. First year we do this, we get a cut, and then every 5 years we would do it. So they did a very beautiful analysis, and back then they said it's not cost effective because they put in their cost $400 for coronary calcium. I think Dan can testify here that we can do that with $80 to $100. And if you put $80 to $100, it would be significantly more cost effective, truly cost effective. So, you know, our approach is, this is the mammography of men, kills more men than, you know, breast cancer kills women. It should go to national guideline. It should become a standard of care. You get your coronary calcium, you know where you are. Now we're working on finding the vulnerability factors that maybe with Johannes and Piotr and other people looking into calcified vulnerability or vulnerable calcification, it might even be able to improve that one even further. We're just looking at the great Addison score, right? We haven't made any improvement in that one. So if you add those incremental, we can very likely reach that 25% Dr. Brownwald or even more. And once there, I think we'll reach the holy grail. We will reach that era that we've been chasing for 20 years now, 50 years, that we turn these people to like cancer, tumor. Now, we gotta do something aggressive and try to, so while we're doing all other things, just societal levels and so on. I want to go to Erling Falk, the father of plaque rupture. Erling?
Yeah, I don't think I can say so much that has not been already said, but you mentioned our vision was to identify, to find the violent people and treat them before they come out. We are talking on primary injuries, not like Jesus.
Yes.
And what have we achieved in the last 15 years?
What?
What have we achieved in that aspect? We have talked about coronary classification, we have talked about carotid ultrasound, but in fact they may improve risk assessment, but even heavily classified coronary will not come close to a risk of 35% of mortality in 1 year. So we are talking about something else. I think we can do risk assessment better, and I think we should be able to improve it beyond the traditional framing and risk factors. And with new tools available and detecting multiple biomarker and and machine learning, we will be able to do better risk assessment. But I don't think we will come close to in an asymptomatic person with this I1 that have 75%.
1 out of 4 will have an event in the next 12 months.
I don't believe it.
Well, we're going to have to make you believe it. So we're going to have to show you.
But I think you would, of course we should be able to do risk assessment better than we are doing.
So imagine we have 2,000 vulnerable patients from this 20-some cohort. These are people who died or had an event.
But you assume there is a signal.
What?
You assume there will be a signal present in these people
No.
that are
I
going
just
on.
have,
that is
yeah, no,
unsafe.
you're right. My philosophy
Maybe
is,
it just happens.
it's not earthquake, Erling.
No,
Not
I think
earthquake.
about earthquake.
Yeah, remember?
I think about earthquake.
We had a motto when we started vulnerableplaque.org. Heart attack is not an earthquake. It can be predicted, therefore prevented. This was 17 years ago, when we did our first. Unfortunately, we haven't cracked this code yet, but I really believe that with all the things that we have seen, have you said, how many of you guys have you driven Tesla on driverless mode? I did, and I was frightened on highway, completely driverless, and I was texting. If that much advancement could be made in the last 5 years, less than 10 years, with machine learning, all these genius approaches, we can do that. It's our job to bring that to our field. So I think with this unique subset of data that we're putting together, we have the opportunity. Okay.